Next, last speaker is Professor Roman. Good, right?
Thank you very much. Ladies and gentlemen, Mrs. and Mr. Chairman, dear colleagues, it is a great pleasure for me to be with you in Japan and to discover this wonderful country, which is Japan. And even though I have a very difficult task to try to sell you the surgery, you, in majority, your IVF aortic specialist. But let's try to see which patient may benefit from the surgery if they are involved by severe advanced endometriosis. So here are my conflict of interest. They are mainly fees I received for organizing training, surgical training for different companies. So when you speak about severe endometriosis, we have a lot of studies. Most of them focus on colorectal endometriosis, which is the most frequent severe form of endometriosis. And inside we may find patients who are infertile and patients who simply wish to get pregnant, but they have a very severe endometriosis. And the endometriosis is a problem in this patient because the mean age of deep endometriosis surgery is around 30 years old, and this is the age of the first pregnancy in Occident. So the question is how to manage the pregnancy intention. So again, the patients with severe endometriosis may wish to get pregnant without having a documentation of the infertility, or may be infertile because they are stage 4, where the probability of pregnancy is very low. So to tell you that you have to do the surgery in these cases, I have to prove you that my surgery will not decrease the rate of pregnancy if you carry out an ART after the surgery, or it is balanced, this decrease is balanced by an increase of the rate of natural pregnancies. And also I can support the surgery by the improvement, a general improvement of health of my patients. So this question is very, very, very frequent in my daily practice because I am involved exclusively in the management of deep endometriosis. So the patients say, I have severe endometriosis, I want to get pregnant, and they ask an advice. If we go back to guidelines, so they were in a brilliant manner presented by Christian, the patient will say, what should I do? I have to go to the IVF or I have to have a surgery? So I answer them, both strategies may be considered. But in the past guidelines, there was mentioned that as we do not have randomized trial comparing the IVF to the surgery, we cannot definitively state which is the best way to treat the patients. And the guidelines say the patients may have surgery if they have pain. And this word pain is somehow embarrassing for me. Because if you refer to the surgeon only patients who see for the ART, and you refer to the surgery only patients who are pain, you can miss some patients who actually need a surgery without being very painful. For example, there are patients who wish to get pregnant but cannot have sexual intercourse because of the pain. Of course, if they do not have sexual intercourse, they are not painful. So this symptom, which has a huge impact on the fertility of natural conception, may be overlooked. So these kind of patients with big endometriosis who cannot have sexual intercourse, I think the surgery is required. Then there are patients who are not painful, but they have a lot of difficulties to void the bladder, to empty the bladder, because they have endometriosis of the parametria, which involve the splanchnic nerves of the bladder. For me, this symptom is terrific because the patients may be destined to have self-catheterization in the long run. So these patients, I think, should be referred for a surgery. The patients who are not painful, but they said, oh, I have a bloating, I have a huge belly, everything, ask me if I'm pregnant. This patient may have a very severe bowel endometriosis, even not very painful, but in this patient, I advise the surgery prior to IVF. The all typical, unpainful by very severe endometriosis is the deep endometriosis of parametria, which is responsible for a stenosis of the ureter, which may lead to silent kidney. Silent means there is no pain. So these kind of patients should be referred to the surgeon prior to the IVF. And I used to do routinely nephrectomies in very young patients where the kidneys are completely destroyed by endometriosis. And last but not least, there are patients with huge endometriosis, but outside the area where the radiologists have or used to look at. So the patients with endometriosis of the sacral plexus, of the sciatic nerve, which have sciatica during periods, but nobody worry about endometriosis. Everybody look at the spine. This patient should be referred for the surgery. My colleague spoke about the endometrioma. So having endometriomas and the risk of surgical impact, negative impact on the ovarian reserve, this is not an argument not to propose a surgery for deep endometriosis, because we can simply drain the endometriomas and remove the deep endometriosis. We can treat them by vaporization, by sclerotherapy, an excellent technique which was born in Japan 40 years ago, and we routinely use in Bordeaux. And it is not mandatory to perform the cystectomy in these patients. Take care about deep endometriosis first. Now, the patients will say, okay, what is the pregnancy rate I can expect if I go directly with my rectal endometriosis, if I go directly in the IVF? And we have some data about this. I can answer them as about 70%. And we have two French studies where my colleagues, who are also friends of me, they looked at the pregnancy rate in women with severe colorectal endometriosis who are sent directly to the IVF. So they observed that they may expect 70% of pregnancies if the patients have up to 4 IVF. But they also observed that the first and the second IVF are responsible for almost all the pregnancies, while the third and the fourth IVF simply increase by a minor, are responsible for a minor percentage of pregnancies. But we can expect if everybody goes up to 4 IVF, which are reimbursed by the government in France, they may expect 70%, up to 70% of pregnancies. Now the question is, okay, but if I go to the surgery with you, what is the pregnancy rate I could expect? And I can answer her, yes, up to 80%. And I have arguments for this, because 10 years ago I carried out the unique randomized trial comparing in women with colorectal endometriosis, comparing the colorectal resection to the conservative management by disc excision or shaving. And these women were followed up to 10 years. So now the article about 10 years follow-up is submitted in GMID. So these patients had the surgery for colorectal endometriosis. But as they arrived, they tried to get pregnant after my surgery. So I could observe that in women who wanted to get pregnant after my surgery, the pregnancy rate was 81%, a majority of them being pregnant naturally. And if I look at only women who were infertile before my surgery, but they went to the surgery because they were too painful or too symptomatic, in this case, in only this subgroup of infertile women prior to the surgery, the pregnancy rate is 74%, with a majority of natural conceptions after the surgery. So this study for me is the proof that the surgery has a benefit on natural conception. And furthermore, in France there is an idea, a folk, that if you want to get pregnant fast, you have to go to the IVF. So I look at my patients after, when they decided to get pregnant and they stopped the pill, who is pregnant earlier? The patient who tried to get pregnant naturally, or the patient who had IVF? And I observed that the patients who were pregnant naturally earlier, and I emphasized the role of the EFI score, which allows to the surgeon to advise after the surgery to the patient. So I tell them, you can try to get pregnant for 9 months, or you have to not stop the pill and go directly to the IVF. So the patient will say, okay, you spoke me about studies done by your friends with the IVF and your data in surgery, but do you have a study which compare in the same population, in the same center, women who had IVF and women who had surgery? So unfortunately, we do not have randomized trial right now, but we have retrospective studies using the propensity score. This is the largest one, which observed that women who had the surgery before the IVF could expect better pregnancy rate than women who had IVF first with the deep endometriosis inside. And on the basis of several studies like this, there are 2 randomized trials ongoing right now in France and in Denmark, and I am actually involved in both of them. So we compare the IVF and the surgery. In the first trial, effort randomized trial, we compare the IVF first to surgery followed by natural conception attempt or IVF after the surgery. In the other one, EndoFert, which is a French multi-centric study, we compare the IVF to the surgery with mandatory IVF after the surgery, meaning that in this second randomized trial, the patient cannot try to get pregnant naturally, they have a pill after the surgery. The problem is that the enrollment, and I answer also to my colleague who asked why we do not have enough randomized trial, because it's very, very difficult to enroll the patients. Because when the patient came to the surgeon, they have already had 2 or 3 IVF. They said, I don't longer want to hear about randomization or IVF. I want to have the surgery. If I came to see you, I want to have the operation. So that's why we work for this randomized trial, but the enrollment is slow. So the conclusion will be within 10 years. Now, some patients started by IVF, and after 2 failures, they ask if it would be interesting to have the surgery to change something. And we have a look in our personal Syria of women having the surgery after 2 or more IVFs. And we observe that if we perform the surgery and then, depending on the EFI, we let them the chance to try, the opportunity to try to get pregnant naturally, or we refer them for IVF, the pregnancy rate is almost 44%. And I think it is better than data observed by my colleagues who carried out the IVF without surgery, where the 3rd and the 4th IVF was responsible for 10% of exceedant of pregnancies. That's why in our daily practice we propose a surgery for deep endometriosis in women who have 2 failures for IVF. Now, if the patients do not go directly to the surgery, it's because someone tells them you have a very severe endometriosis, the surgery is too difficult, the risk of complication is scary, and the patient is frightened by this. So is the postoperative complications rate so scary in order to avoid the surgery? So if we look again to our data, we perform 300 correctal endometriosis a year, so your experience. But we cannot avoid postoperative complication. This is an evidence, it's obvious. And we have 3.4 fistula. The fistula is the most terrific complication after a deep endometriosis. All the patients said, will I have the stoma or not? So we have 3.4%. We have also pelvic abscess, but they are much easier to treat. And this should be put in balance with what I have already said. 80% of pregnancies with most natural conceptions, natural conception is very important, because if you refer the patient for IVF, there is no natural conception. With the long-term improvement of pain and quality of life 10 years after the surgery, patients enrolled in the randomized trial have a constant improvement of their quality of life, and the very low rate of colorectal recurrences after the surgery. If the surgery is well done, only 5% of patients will recur 10 years after the surgery. And if you look to only patients who have a complication, this is not the end of the world, and this is not everlasting infertility. Because we had a look at in 3 centers, we checked the patient who had the complication with a reoperation after the first surgery, and we observed 42% of pregnancies. So it is less than if they do not have complication, but it's still correct. Now, the patients with low ovarian reserve. The low ovarian reserve is frequently an argument against the surgery. The problem is that patients with low ovarian reserve will have worse results in IVF, because the ovaries will not answer. So I think in patients with low ovarian reserve, there is maybe the population of women where we have to fight to help them to improve the natural conception. And we had a study where we involved all the patients who had the surgery for severe endometriosis, depending, and we analyzed the results depending on the preoperative AMH. And you observe that even in patients with AMH less than 1, where the surgery was done because they were painful, or there were clear indications for the surgery, the postoperative pregnancy rate in women who attempted to get pregnant was 68%. But you observe that the lower the ovarian reserve, the higher is the percentage of natural conception, and the lower the percentage of ART, meaning that in low ovarian reserve, as you know, the ART works less than in women with normal ovarian reserve. So it is not forbidden to perform the surgery for severe endometriosis, complex endometriosis in women with low ovarian reserve, if arguments exist. But we can also ask differently. If a patient has a very severe endometriosis with a lot of involvement of organs, is it always safe to refer her for 1, 2, 3, or 4 IVF, hyperstimulations? And these questions was assessed by the team of Cochin Hospital, who stated, no, the patient who have endometriosis and hyperstimulation are not more painful after the stimulation than before. So performing the IVF is safe in patients with endometriosis. Okay, these data were confirmed by the colleagues from Denmark. But if you look at the population, the women are not very painful at bedside. So if you take the overall population of endometriosis, you can do IVF. This is not a big problem. But if the study done by the same Danish team focuses only in women with colorectal endometriosis, in 13% of cases, meaning 1 patient out of 7, they had to stop the hyperstimulation because of the pain of patients. They had 2 patients with occlusion during the hyperstimulation and 6 patients with subocclusion. This patient had the surgery, and after the surgery, 6 became pregnant, among which 1 naturally. So take care with the hyperstimulation in patients with very severe disease involving the rectum with bloating. In my daily practice, where the patients come after IVF, I used to ask them, do you feel that the IVF impaired your symptoms? And in very, very, very frequently, they said yes, there was a before and after the IVF. I cannot tell you that the IVF was responsible, or simply stopping the amenorrhea to perform the stimulation is the main factor, but trying to get pregnant with severe endometriosis usually impair the symptoms. And we also carried out a study where we try to measure, to estimate the risk of the growth of the nodules. And we focused only on colorectal endometriosis because it's easier to measure. A rectal nodule has a length and a thickness. So it's easier to measure than a nodule of the parametrium. And you observe that in women, during 3 years, women who are not in amenorrhea, meaning who try to get pregnant either by IVF or naturally, in 40% of cases, there is an obvious increase of the nodules. So the disease may progress during the pregnancy attempt. And last but not least, sometimes when I performed the surgery, I said, oh my God, if my colleague who performed the ART had been aware about this pelvis, I'm sure he would not have put the needle inside, because usually the ovaries are above the rectum, so there is actually a risk of injury of the rectum during this punction, while after the surgery you have this kind of pelvis, so it's safer. Now, after this talk, I would be very happy if you keep on mind that the surgery does not impair the fertility. So if we can rule out this fake news, which is the surgery renders the patient infertile. But it does not mean that everybody should go to the surgery. So I think that the management of endometriosis is a custom-made management. It's not a pret-à-porter. It's a custom-made management. The problem to speak together is that we are usually around the patient 3 specialties with different angle of view. Me, I am surgeon, so I have a high prevalence of severe case. So behind each patient, I see the risk to progress to a very, very, very severe surgery and a lot of complications. So maybe I push to the surgery in advanced endometriosis. The colleagues with ART have the experience of very successful IVF, high-rate pregnancies, so they say, we can go to the IVF, it works very well. While the gynecologist or the GP, who sees very, very rarely the patients with severe endometriosis, say, no, it's not a problem, the endometriosis is not a problem, it's in your head. So that's why it's very difficult. The patient may be confused in this triangle. That's why the multidisciplinary meetings are very, very useful, but the multidisciplinary meetings should involve people who have experience in this disease. So if anyway you have a patient with severe endometriosis, if you want to go to the IVF, to propose the IVF, because you do not have a surgeon for various reasons, my advice is to start by assessing the disease, to see where the lesions are, their size, their severity. Then ask the advice to an experienced surgeon. Because if you ask the advice to a non-experienced surgeon, you say, oh, don't touch her, it is very, very difficult, the huge risk of complications. So ask the advice to an experienced surgeon. Then adopt custom-made management, and if you do the IVF, you can leave an amenorrhea, because anyway you have to block the ovaries before the stimulation. So give her a pill between 2 stimulations. And of course, don't push your luck too far in order to avoid complications such as occlusions or bladder dysfunctions. So thank you very much. And so I arrived in Japan 10 days ago. That's why this morning I added this with my family. So I'm the first time in Japan. That's why I added a last slide where I said thank you to Japanese colleagues and people for being so kind, so honest, so respectful, so hard workers, and for making the life in Japan so safe and pleasant. And I think that you should be a model for other people.
Thank you so much. とてもありがとう。Dr.
ありがとうございます。
Any comment?
Wonderful talk, thank you. I have a question. I'd like to ask your opinion, the mechanism by which the deep endometriosis resection has a favorable effect on fertility.
But about the bowel?
Bowel, yes.
Yeah, but this is the goal of the two randomized trials. To assess if the complete treatment of the endometriosis by bowel resection or complete shaving or disc excision has an impact on the IVF. And both randomized trials are based on a hypothesis that in the arm of patients with surgery, the pregnancy rate will be higher by 15%. So both randomized trials have this hypothesis that it works better if you perform the surgery. But of course, as you clearly specified, if the surgeon removes the endometriosis but also kills the ovaries, of course the pregnancy rate will be very low. So you have to dissociate the treatment of the deep endometriosis, which should be complete, to the treatment of the ovary, which should be individualized on the basis of the ovarian result.
But why? I mean,
why it happens?
Yes.
Which is the explanation? But we don't know. But maybe I think all this environment of disease and inflammation, and of course we do not speak about hydrosalpinx. I think all these factors are an unfavorable environment for the pregnancy, for nidation, and for all this.
So that the quality of egg improve, or the endometrial environment getting better?
Either the egg or the local conditions for the uterus to receive. Because sometimes the egg are based on the preservation on the oocyte retrieval before the surgery. So the oocytes are from the pelvis with endometriosis. However, the pregnancy rate looks higher. This is based on retrospective studies. Maybe it is possible also that the randomized trial show there is no difference.
Thank you. Interesting.
Coming back to what I said also earlier about the standardization or the transferability of data, when you have your, when you do studies with rectovaginal disease and especially fertility, how do you ensure that, well, I would assume that patients who have tubal disease, ovarian disease, are probably slightly different to those who don't have it in rectovaginal disease only, so to speak.
Of course.
So how do you put them into studies, or do you separate them? So
no. So in studies, retrospective studies, which are actually prospective, because we record our data prospectively. We have a database, prospective database. Of course, in this case, we'll just make an adjustment on multivariate analysis. That's why it is important to carry out a randomized trial where all these other factors of infertility are balanced by randomization between the two arms. And in this case, we'll have the answer if there is a difference depending only on the surgery. But otherwise, the problem of endometriosis is the heterogeneity. So and then there is also the sperm. It may interact. So it's there are a lot of confusion factors. That's why from this presentation, what I want the take-home message is that the surgery is not dangerous. The surgery may improve the fertility rates, the pregnancy rate, and it can be done before the IVF without harm. It can also be harmful on the ovaries. But then it's a custom-made management where we have to to handle. Of course, we record when we decide in our multidisciplinary meetings. We check everything, including the sperm qualities, and in order to take the best choice, the choice who seems to be the best.
Thank you, Professor Roman. I really enjoyed it, and more for Monash-Idin. As you challenge me, I'm going to challenge you. The field with the most progress in medicine is child oncology. And the reason is that in that field, they have done trials, and trials. Now, I cannot believe that if you're able to let your child with one life randomized for 2 different treatments, that we cannot randomize women with endometriosis. That issue is not with the women, it's with us. And with the funding that now is available in France, and congratulations on that, and in Australia also, I think we really have the obligation to do these trials. I'm sorry to confront you again. I'm Dutch, so that's a little bit my style. I apologize for that. But if you like Japan, because everybody is so nice to each other, then we have the obligation to be nice to our patients, and specifically the patients in the future. That's my comment, and I really look forward to the outcome of your trial.
Yeah, I fully agree with you. I am not only surgeon, I also PhD in epidemiology, and to date I wrote the protocols for 5 randomized trials. So 2 of them are finished, 1 is ongoing, the effort, and 2 are about to start. So I feel, and particularly the endo-randomized trial, which was the first one, was based on an hypothesis which was not confirmed by the surgery, by the trial. And I remember when the trial was published in Human Reproduction, the editor-in-chief said, that's why the randomization is the cornerstone of the clinical research, because it may or may not confirm what we believe, because I was believing that the conservative surgery works much more better on bowel function than the resection. And I could not confirm. So the randomized trial is very, very, very interesting and mandatory, but they are difficult to do.
Okay, thank you. It's time to close this session. Thank you very much for the nice present and active discussion. Thank you.